Just let me share my screen. So I hope all of you can see my screen now. I'm going to make it full screen. Welcome all of you to the 68th Pain Journal Club. And today we are going to discuss another very important topic. And this topic today for the 68th Pain Journal Club is the MSK ultrasound on elbow and wrist. Just let me mute everyone. Okay. So the topic for today is uh, elbow and wrist, and we have some exciting speakers and faculties here with us. So pain medicine world over has got diverse issues, variable standards, and different learning requirements. Uh, Different offerings are there, and money and time are two important um, things which prevent physicians from learning more about this unique branch. And to overcome this, Mumbai Pain School is an initiative of Panisha Spine Wellness and Pain Relief Center. And we are mainly focusing on online education through various online channels. We have got some good reviews, good response from the physicians who want to learn about pain. Most of our content is free as well. It is on demand. We also have paid content. We arrange certain workshops, which are the hands-on workshops. We are fortunate to have expert faculties from all over the world. It's said that the best teachers, they teach from the heart and not from the book. So what is a journal club? It's nothing, just a club where we are, instead of dancing together, we are just going to critically evaluate the recent academic literature, which is based on a defined subject. We value attendee participation, so please type any questions, comments, suggestions. Those of you are joining straight from social media as well, and we will take it up. It is very tough to be regular. Every time we see new faces coming in, and of course, even Harrison, which is probably arguably the most famous book in medicine. This one also, he also used to conduct his own journal club, which used to happen twice a month for critical evaluation of the academic literature. We value time, so I request the speakers to stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I practice in Mumbai, but today we have with us distinguished faculties. I would just like to introduce them. So we have Dr. Madan Pandya. He's MD, SIPS, and RMSK, very difficult qualifications to achieve. He's a consultant in anesthesia and pain medicine at Indira Gandhi Government General Hospital and PGI Pondicherry, I think since 2015. He's also a consultant in pain medicine at Pain Specialty Clinic at Pondicherry, India. He's an organizer come course director of Pondicherry Musculoskeletal Intervention course, many other qualifications as well. But prominent is that he's a renowned faculty in teaching MSK ultrasound and intervention. His courses are very popular. And he's also the NISORA US Pain app contributor. So I think he's here with us. Dr. Madan, are you here? I think he's joined. Just let me check.
Am I audible, Sidharth?
Yeah, of course. Hi and welcome to the Journal Club. And I think I'll,
Hi.
yeah, great. So let's proceed. And I'd like to introduce uh, our second faculty, who is Dr. Sanjog Mekewar. He's done his DAD NBN fellowship in pain medicine. He's currently consultant uh, spine and pain physician at multiple hospitals across Pune, including the BJ Medical College and Sassoon Hospital. He's also the director of Jivisha Pain Management Center. And his area of interest is region med and spine endoscopy. So, welcome, Dr. Sanjog. Are you there? Okay, I think I need to make him co-host. So, just a minute. Yeah, Dr. Sanjog, you can now unmute yourself.
Yes, thank you for the introduction, sir. And Happy New Year to everyone.
Yeah, great. I think today we'll have limited attendance. Most of us have started partying already. So thank you, Dr. Sanjog and Dr. Madan for joining us. So over to you. I think Dr. Sasmit, you'll present first.
Okay, sir. Yes,
Yeah.
sir.
Yeah, okay. Okay, so over to you, Dr. Sasmit. We can start with the first presentation. Yeah, I can see your screen. Can you put up your CV slide? I will just introduce you.
Yes, sir.
Yeah, so Dr. Sasmit Deepak Lotliker is MD and a fellowship in pain management is done from DYPU University in Mumbai. He's a consultant interventional spine and pain physician at multiple hospitals in Goa, including Manipal Hospital and Borkar and Menzies Hospital. He's a director of Thavasmi Spine and Pain Clinic, Panji in Goa. So over to you, Dr. Sasmit.
Good evening, everyone. Thank you, sir, for the introduction. So today I'll be presenting this paper, that is the ultrasound of the elbow with emphasis on detailed assessment of ligaments, tendons, and nerves. So this is basically a review article published in the European Journal of Radiology in December 2014 by Dr. Michel de Messiner et al. At the Department of Radiology in University of Ziekenhuis, Brussels, Belgium, University of Michigan, Ann Arbor, USA, and Wake Forest University, Winston-Salem. Coming to the introduction, so ultrasound usually offers some advantages over MRI owing to its higher resolution. It also allows for better depiction of fine nerve branches. There is better appreciation of subtle alterations in fibrillar ecotexture of tendons and ligaments on ultrasound. Also, ultrasound helps us in dynamic real-time assessment of the integrity and continuity of tendons and ligaments in positions of stress. We can also compare with the asymptomatic side, and there is a power Doppler option available which is valuable in diagnosing tendinopathies such as tennis elbow or golfer's elbow. The disadvantage is the operator dependency as well as technical difficulty, but it has been overcome by proper training. Coming to the aims and objectives of this article, to discuss the detailed ultrasound anatomy of the tendons, ligaments, and nerves around the elbow using cadaveric correlation, and to provide tips and tricks for evaluating difficult anatomical structures. To start with the discussion, first we come to the ligaments. Let's look at the medial ligaments of the elbow. So here, the ulnar collateral ligament is the most important ligament over here. It consists of the anterior band, the posterior band as seen in the figure, and the transverse band. This forms a major restraint to valgus stress, and it is commonly injured in the setting of throwing injuries and sports. Now, this is how the probe position should be held to see for the anterior band of the ulnar collateral ligament. The elbow should be put in slight flexion as this allows for optimal alignment of the ultrasound probe along the course of the ligament. This is the longitudinal view of the anterior compartment of the ulnar collateral ligament. If you see here, the ulnar collateral ligament is not very clearly visualized, but if you tilt the probe slightly, it takes care of the anisotropy, and also the multifibrillar aspect of the ligament is visualized much better. So this is how we visualize it in the longitudinal view. Coming to the posterior band, the probe position as we see over here is similar to that of assessment of ulnar nerve and ligament of Osborne. The posterior band spans the humeral ulnar joint like a hammock. So if you see here, this forms the hammock in which the posterior band is seen over here. The ulnar nerve is located just adjacent to it. The transverse band also courses between the ulnar insertions of the anterior and posterior band, but it is not much of importance. Coming to the lateral ligaments of the elbow, we have here first is the radial collateral ligament. The next one is the annular ligament, and the third is the lateral ulnar collateral ligament. Coming to the radial collateral ligament, probe position for this, if you see in this image, it is similar to that for the assessment of extensor elbow tendons. And first you have to localize the concavity of the distal humerus. The radial collateral ligament will insert on the humeral epicondyle in the groove between the anterior and the posterior tubercle, and it courses towards the radial head where it joins the annular ligament. The first image here is a longitudinal view of the radial collateral ligament. If you see over here, in this we can see the extensor carpi radialis brevis tendon above the radial collateral ligament, and if you visualize, it can be a tear also seen in this ligament. This is the short axis view in which we can see the ligament, the radial collateral ligament and the lateral humeral epicondyle. Coming to the annular ligament, so the probe position to note here is the cobra position, as we can see in this image over here. Annular ligament, it forms a band around the radial head. So here in this image we see is the radial head, and this is the band of the annular ligament, and it goes and inserts onto the ulna. When the probe is placed in a transverse plane, thin fibers of the annular ligament can be seen to insert into the ulna, as seen in this picture. Coming to the lateral ulnar collateral ligament, again the position for assessment of this is the cobra position, but here we have to move the probe slightly anterior in between the radius and the supinator crest, and then we get this image where we can see the lateral ulnar collateral ligament. This is the radius and this is the ulna. Few delicate vascular structures can be seen between the lateral ulnar collateral ligament and the adjacent muscles, and this will constitute an excellent landmark to identify our position. Coming to the tendons of the elbow, first is the medial elbow tendon. So this is the schematic diagram, and this is the cadaveric dissection of the medial elbow tendons. From top to bottom, if we see, we have the pronator teres, the flexor carpi radialis, the palmaris longus, flexor digitorum superficialis, flexor carpi ulnaris, which has got two heads. This is the humeral head and this is the ulnar head. The method for visualization of this is the elevator method. That is, we first identify the flexor carpi ulnaris and then go one step at a time. Now this is the short axis view of the medial elbow. Here we can see all the medial tendons of flexor tendons over here, and which are saying on the medial epicondyle. In this view, we can actually see the two heads of the flexor carpi ulnaris, and in between the two heads, this is the ulnar nerve which is situated over here. So it forms a dumbbell-shaped structure which actually covers the ulnar nerve. Coming to the lateral tendons, so here again we have the schematic diagram and the dissection of the lateral tendons. So from top to bottom, we have the brachioradialis, the extensor carpi radialis longus, the extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, the extensor carpi ulnaris, and the anconeus. If you see here, the brachioradialis and the extensor carpi radialis longus will be actually inserting themselves onto the supracondylar ridge, whereas all others will be inserting onto the condyle, on the epicondyle. So this is the short axis view of the lateral epicondyle just before the insertion of the tendons. So if we see here, this is the supinator muscle, and these are all the extensor tendons which are inserting over onto the lateral epicondyle. This, if we go, we see the beak appearance of the extensor carpi radialis brevis. This is again a longitudinal view of the extensor of the lateral epicondyle. We can see the extensor carpi radialis brevis tendon over here, and this is covered by the extensor digitorum muscle. If we move the probe slightly above, that is on the supracondylar ridge, we will see the extensor carpi radialis longus tendon. So as we have seen in the previous image, the extensor carpi radialis longus will get inserted into the supracondylar ridge. This is exactly what we see once we move the probe slightly above. Coming to the biceps tendon, the investigation of the biceps tendon from an anterior approach is quite difficult. Hence, we have to follow multiple approaches and combine various approaches to actually visualize the biceps tendon. Now, the easiest way is first identify the biceps tendon in the transverse plane just above the elbow joint. So here we will see something called as the BAM sign. In BAM sign, we mean B stands for the biceps tendon, A stands for the brachial artery, and M stands for the median nerve. So in here we have the biceps tendon, brachial artery, and the median nerve forming the BAM. This is the cadaveric dissection of the biceps tendon, which shows the bifid biceps tendon, and this is seen on the ultrasound as well. The bifid biceps tendon. Now, at the level of the biceps tendon, where it is located adjacent to the brachial artery, there can sometimes be a thin band-like structure which is seen crossing over the artery, and this is called as the lacertus fibrosus, which we can see here in the cadaveric dissection, as well as over here, this thin band-like structure which is present over here on top is the lacertus fibrosus. We can visualize the basilic vein on top over here, superficial to the lacertus fibrosus, which helps as a very important landmark to identify the lacertus fibrosus. And this is the position of the probe, how we examine the patient. Coming to the biceps tendon approaches, so there are various approaches as I've told you. The first one and the most important one is the anteromedial approach. So as we see here in the diagram, this is the anteromedial approach. This is the position of the probe. So from this position, we can actually visualize the radial tuberosity and see the biceps tendon inserting onto it. So if we see here, this is the biceps tendon and this is the radial tuberosity. So we can see the biceps tendon coming and getting inserted into the radial tuberosity. This radial tuberosity is best seen when the forearm is in supination. The brachial artery forms an acoustic window through which the biceps tendon can be visualized. Coming to the next approach is the lateral approach. So if we see here in this diagram, this is the lateral approach and this is the probe position. So the probe is held in the coronal plane along the lateral aspect of the radius. Now in this position, we can actually see the supinator muscle and the biceps tendon here in the bottom, but insertion of the biceps tendon is not visualized over here as it goes behind the radius. This is the radius bone. So this position is useful especially to perform dynamic studies, but we cannot visualize the insertion of the biceps tendon. Coming to the third approach is the transverse approach. So the position here of the forearm is the cobra position as we have already discussed before. So here we will see the transverse approach of the biceps tendon. So here we can actually visualize the insertion of the biceps tendon on the radial tuberosity. So here is the biceps tendon and here this is the radial tuberosity. So this position is more important to visualize the insertion of the biceps on the radial tuberosity. So now to examine the biceps tendon, we have to combine all the three approaches for the examination. Coming to the nerves, so first is the ulnar nerve. The ulnar nerve is located in the cubital tunnel. It is covered by the Osborn's ligament. And at the bottom of the cubital tunnel is formed by the posterior band of the ulnar collateral ligament. It may be compressed between the humerus and the ligament of Osborn. Distal to the cubital tunnel, the ulnar nerve will course between the humeral and the ulnar heads of the flexor carpi ulnaris, and there's a fibrous arc which connects both the heads. So this is the arcuate ligament, and this forms a potential area for compression of the ulnar nerve. So this, in the first image, is a cadaveric dissection. We can see the Osborn's ligament covering the cubital tunnel over here. In this image, the Osborn's ligament has been removed, and from here we can actually visualize the two heads of the flexor carpi ulnaris, the humeral head and the ulnar head, and this is the ulnar nerve which runs between the two heads of the flexor carpi ulnaris. Coming to some of the pathologies, so there can be nerve subluxation, snapping triceps syndrome, in which there is subluxation of the ulnar nerve and medial head of the triceps muscle. There can sometimes be anconeus epitrochlearis. So this can be present instead of the ligament of Osborn, and this can cause compression of the ulnar nerve. The normal thickness of the ulnar nerve is 8 mm square. Other important findings of the ulnar nerve include focal thickening, a notch sign, hypervascularity, and a bifid or trifid ulnar nerve. So here we can see the muscle variation as we discussed, anconeus epitrochlearis, which is seen as the arrows. So this is the anconeus epitrochlearis, which actually is present in place of ligament of Osborn, and it will cover the ulnar nerve. So this can be a potential site for compression of the ulnar nerve. Coming to the radial nerve is usually found in the spiral groove along the posterior aspect of the humerus. Now, as we see in this diagram, the radial nerve just before the proximal edge of the supinator muscle over here, it will divide into two branches. This one here is the superficial radial nerve. Here, this is the posterior interosseous nerve. The superficial radial nerve is a sensory nerve, whereas the posterior interosseous nerve will be a motor nerve. This superficial radial nerve will continue distally to emerge adjacent to the tendons of the first extensor compartment, and the compression of the radial nerve over here can result in Wartenberg syndrome. So this is the transverse ultrasound image of the radial nerve. This is the position of the examination of the radial nerve. Here we visualize the posterior interosseous nerve. So now this posterior interosseous nerve is a motor nerve, and it enters between the two heads of the supinator. So at this entrance point, the nerve is covered by something known as arcade of Froese over here. As you can see in this arrow marked over here, this is the arcade of Froese, which will cover this is the fibrous band which will cover the radial nerve, and this is a potential site for nerve compression. So these patients will present with finger drop as well as pain. Coming to the next image, here this is again a longitudinal image of the posterior interosseous nerve. So this entire thing is the posterior interosseous nerve. So if we see here, the posterior interosseous nerve is present between the superficial as well as the deep head of the supinator muscle. And if you see the actual dimensions and the caliber of the nerve, it changes as it enters the supinator muscle. So we can nicely trace the radial nerve in the longitudinal image in between the two heads of the supinator muscle. This is the position of the probe and the arm in which we examine this. Coming to the median nerve, this nerve again, as we have discussed earlier, it can be found at the level of the elbow fold and be identified by the BAM relationship. That is the biceps tendon over here, the brachial artery, and the median nerve. So the median nerve will be the most median over here. Now, what are the different sites for compression of the median nerve? First one is the ligament of Shutters. This is a fibrous band which courses from a supracondylar process of the humerus to the medial epicondyle. Second is the Lasseter's fibrosis, which I have already discussed previously. This is a thin band-like structure at the level of the biceps tendon, which is located just adjacent to the brachial artery. Third, the compression can occur between the humeral and the ulnar head of the pronator teres muscle. So in this, we have to follow the median nerve distally from the elbow fold, and when the ulnar artery is seen underneath the median nerve, that time a band-like structure can be visualized. This is the short head of the pronator teres muscle, which is variable in size. So this is the ultrasound image, is the transverse ultrasound image of the median nerve. The median nerve is seen superficial to the short head of the pronator teres, and here we can actually see the ulnar artery over here. So this head is typically seen at the level of the ulnar artery just deep to the median nerve. Next site of compression is the sublimis bridge. Now what is this sublimis bridge? It is a fibrous arch present between the radial and the humeral heads of the flexor digitorum superficialis muscle. So we see in this diagram over here, this is the humeral head and this is the radial head of the flexor digitorum superficialis muscle, and this forms a bridge. So this is the median nerve which goes in between the bridge, and this forms an important site for compression of the median nerve. So this bridge is easily recognizable over the median nerve, slightly distal to the pronator teres head. So if we see here, this is the transverse ultrasound image. This is the position of the arm and the probe, and these are the two heads of the flexor digitorum superficialis, which are referred to as the sublimus bridge. So the medial nerve will be present deep to it, as seen by the arrow over here. So this forms an important site for compression of the median nerve. The last one is known as Kilo-Nevin syndrome. So this is a result because of the injury of the anterior interosseous nerve. So in this, the patient usually presents that he cannot pinch between the thumb and the second finger. It is a thin branch, so it is more difficult to visualize. So what is the trick to visualize this nerve here? Displace the probe distally until the triangular origin of the flexor muscle for the thumb is brought into view, and then ask the patient to make movements with his thumb. So the anterior interosseous nerve will course just adjacent to the ulnar border of this muscle origin. So here we see the transverse ultrasound image of the flexor pollicis muscle origin. The triangular shape we can see over here. This is the triangular shape and the artery alongside the edge of the muscle. So to conclude, ultrasound is an excellent imaging modality for the assessment of ligaments, tendons, and nerves about the elbow. The advantages of ultrasound are its high resolution, dynamic capability, and the ability to compare the findings with the asymptomatic side. Valuable tricks and tips are provided to depict the elbow anatomy, significantly shorten the learning curves, and for better comprehension of the anatomical features, anatomical dissections have also been included. So the limitations accepted by the article were none. Coming to the critical analysis, important tricks and tips were mentioned for better identification of the structures. Stress was given on correct positioning of the patient and the probe by means of pictures being attached alongside the ultrasound image, so which helps in actually visualizing what will be the correct position of the patient. And anatomical dissections were included alongside the schematic diagrams, so this helped in better understanding of the anatomy. So the take-home message is that ultrasound is an excellent imaging modality for the assessment of ligaments, tendons, and nerves about the elbow, and high resolution ability for dynamic scanning as well as the ability to compare the findings with asymptomatic side will make it a good tool for diagnosis and treatment. Thank you.
Thank you, Dr. Sasmit. That was an excellent presentation. Over to Dr. Aanchal for the second presentation for today. Dr. Aanchal, you can put up your CV slide. I will just introduce you. Then you can begin your presentation. So Dr. Aanchal Sharma has done her MD anesthesia from BGI Chandigarh. After that, she's done her fellowship in pain medicine from Chicago, United States. She's board certified from American Board of Pain Medicine. She's a senior consultant and head of department at for pain medicine and palliative care at the BLK Max Super Specialty Hospital in New Delhi, India. So over to you, Dr. Aanchal. You can make it full screen. Yes.
Can you hear me now?
Yeah.
Thank you for the introduction. So I'll be discussing on this paper. The title is a steroid injection in both compartments more effective than an injection in the extensor pollicis brevis subcompartment alone in patient with De-Quervain disease. It was a randomized control trial published in Clinical Orthopedics and Related Research Journal in 2022. And Dr. Jung, Dr. Beg, and Dr. Lee was the authors. And it was done at the Department of Orthopedic Surgery at Seoul, Republic of Korea. So coming to the introduction, so before we start this paper, I have a disclosure that I've added few pictures, which is freely available on Google Images for the better understanding for the one who have not seen patients with De-Quervain disease or not visualized with the ultrasound. So ultrasound images included are one given in the picture. It's just the anatomical understanding pictures are added. So De-Quervain disease is a stenosing tenosynovitis of the first extensor compartment of the wrist, which is composed of abductor pollicis longus and extensor pollicis brevis tendon. So there are two tendons. And if this happens, the treatment options we have is non-surgical methods like limiting the use of thumb, using a brace, a steroid injection, or if these are ineffective, then surgically releasing the tendon sheath of first dorsal compartment. Among non-surgical procedures, a steroid injection is often performed with as many as 83% of the patients achieving pain relief after the injection. So just showing you what this first compartment is. This is the abductor pollicis longus, and this is extensor pollicis brevis. And this is a radial styloid process. So this is a extensor retinaculum, which forms the roof of this narrow fibroosseous tunnel. So several anatomic variations could play an important role in response to this treatment after injection. And most relevant variation is the presence of an intracompartmental septum between these two tendons. And this results in subcompartmentalization of the first compartment, which makes it difficult for the injection to reach the entire tendon sheath effectively. Therefore, some have suggested that injection into each subcompartment may make it more likely that injection will provide pain relief, as main lesion of De-Quervain is in patients with septum only. And it is causing the stenosing tenosynovitis of actually extensor pollicis brevis tendon. So in anatomic studies, an intracompartmental septum was usually present at the radial styloid in the first compartment, creating a separate narrow compartment for EPB tendon. And failure to inject steroids into EPB sheath could result in persistent symptoms despite the injection. And just as like if you do a surgery and the EPB compartment was unreleased, then it will also lead to a persistent symptom even after the surgery. So previous studies before this study have compared injections into both subcompartments with injections into a single compartment. But authors did not find any report comparing injections into the EPB, just the EPB subcompartment, as compared to injection in both the compartments. So they asked the question, do patients who receive steroid injection in EPB compartment alone have lower pain scores at 6 weeks and 3 months after ultrasound guided injection as compared to patients who receive an injection in both subcompartments? And second question they asked was, do patients who receive steroid injection in EPB subcompartment alone experience fewer steroid-related side effects than patients who receive an injection in both subcompartments? So the way they did this study was, it was a randomized control study done at a single center between August 2018 to March 2021. They included all the patients in their hospital who made a diagnosis of De-Quervain disease and who had an intracompartmental septum between both the tendons. The diagnosis was based on history and examination, and the injection was just done by two surgeons who were also authors here. And they are experienced hand surgeons with 10 to 20 years of experience. They performed all the injections. So the way they randomized, the way they recruited the patients were the first history and physical examination. So pain at the radial side of the wrist, tenderness of the first compartment, positive Finkelstein test result. Finkelstein test is nothing but if you just ask this thumb to be flexed and make a fist and just do a ulnar deviation, and if it causes the pain at the radial side, then it is a positive Finkelstein test results. And this is one of the diagnostic method for diagnosing De-Quervain. And then the negative findings for differential diagnosis of radial side wrist pain, like carpometacarpal arthritis will also cause similar pain. So they ruled out that with wrist radiographs. And then US examination should show APL and EPB tendon swelling, fluid collection with a tendon sheath, and hypoechogenicity around the tendon. They excluded if patient already had history of steroid injection in last 3 months, pregnant women, rheumatoid arthritis, age less than 18 years, if there was a fracture or already had a surgery on that side, and lack of clear septation or partial intracompartmental septum also was excluded. So after clinical diagnosis was made, during sonographic examination, they identified first, as you can see in the picture, hyperechoic distal radius at the base of the tendon. That was crucial to ensure that sonographic scanning was performed exactly on the first extensor compartment. Then the presence of septum had to be found to include the patient into the study. So they determined that by observing the intervening hypoechoic area between the tendons and hyperechoic area of the distal radius at the base of the tendon simultaneously. So the complete septum had to be there. So there was another thing called distal incomplete subcompartmentalization, which they defined as when APL and EPB ran in the same sheath at the level of distal radius, but with each tendon running into separate subcompartment in the distal portion. So proximally they were together, but distally they separated. So this is incomplete subcompartmentalization, incomplete septum. So they did not include that. So once the patient showed a definite and complete intracompartmental septum of the first compartment, then US guided injections were performed. And the patients were divided into 2 groups. First, which received the injection into both subcompartments, that is the APL and EPB tendon separately. And then there was a group which just received the injection into EPB compartment. Randomization was done using computer-generated random numbers. And then, once randomization was done, the patient was included into the group. Number envelope was opened, and he was allocated into a group. And although enrolled patients and hand surgeons who performed the steroid injections could not be blinded to the injection method, but the one who assessed the outcomes, that surgery resident was not involved in the patient management. So study was approved by IRB, and the study was registered in the Clinical Research Information Service. And but after the registration, they had one thing modified, which was done to a protocol, that dash score was removed, which was included before. And this dash score is disabilities of arm, shoulder, and hand score, because it is affected by many other upper extremity conditions. So they said that they could not fully reflect de Quervain disease severity only. Hence, VAS score was the only thing which they kept as a primary endpoint. So 112 patients were, found to have a diagnosis of de Quervain based on history and physical examination, and ruling out the other. But in this 112 patient, no septum was found in 40 patients, and incomplete septum was found in 22 patients. So only 50 patients which was left was randomized. They were allocated to both the groups, one both compartment group, one EPB compartment group. In both the groups, one patient was lost to follow-up, and he did not register pain level at any point, so he was excluded. So we were finally left with 24 patients in each group. The group characteristic at baseline was they had higher preponderance of women, age was similar, affected side was dominant versus non-dominant was also similar, duration of symptoms were around 3 to 5 months, and pre-injection VAS scores were also similar. So they did use a 15 megahertz hockey stick linear probe for the injection. The position was sitting position with affected wrist placed on a pillow. A transducer was placed along the short axis of the first compartment. An injection was performed in plane. The injection was performed from dorsal to palmar side of injection, because that was free of overlying veins and superficial branch of radial nerve. Medication which was prepared was solution of 0.5 ml of 2% lidocaine and 0.5 ml of triamcinolone. And this whole 1 ml was injected. We'll see in few next slides. No LA was used on the skin, and injection was done with just 25 gauge needle. So As you can see, this is the same thing I explained before. They had to see a tendon, the radial styloid process, and they figured out both the tendons, and their complete septum had to be seen before performing. And then the both compartment group. Here, if you see, the US guided injection was performed in each compartment separately. This is the needle going to the APL tendon, and they injected the medication. Then the needle was withdrawn and kept just at the EPB tendon site, and the remaining 0.5 ml was injected. So 0.5 ml was injected into each group. But if it was just EPB group, then they did not go till the APL. They just kept their needle here close to EPB, and 0.5 ml was injected. So in the both group 1 ml, and in the EPB group only half ml of the medicine was injected. And real-time ultrasound was used to observe whether the subcompartments were inflated with the solution. So outcomes they measured at other than the baseline was at 6 weeks and 3 months post-injection. They evaluated pain intensity using VAS score, and complication related to steroid injection was also noted down, including if they had any numbness, tendon rupture, skin hypopigmentation, which they defined as lighter color to completely white color. The patient who did not respond to the injection and wanted further treatment were offered surgery. So no second injection was performed. If they did not get a relief after first injection, they were offered surgery. So US ultrasound inter-observer reliability, the inter-observer reliability of ultrasound assessment for intercompartmental septum was evaluated by recording the representative images. So the images which were stored from each patient, they were assessed under blind conditions by other investigators. And inter-observer reliability between ultrasound investigators were evaluated using intra-class correlation coefficient. So this intra-class correlation coefficient is something, you assess how much reliably that thing was done. So if it is less than 0.5, it is a poor, poor reliability. But if it's 0.5 to 0.7, it's good. And if it's more than 0.9, then it's a very significant reliability. So there was no question about, whether they were not able to diagnose the septum with the ultrasound. So statistical analysis was done for VAS score was, as I told, was a primary outcome variable. They calculated sample size because the previous study on this was by calculating that they said that if they take the sample of 21 patients per group, it would provide a power of 80%. And to account for the possible loss of 10%, they enrolled 24 patients in each group. Quantitative data was assessed with t-test and Mann-Whitney, and qualitative was assessed with chi-square and Fisher. And baseline VAS score was assessed with Wilcoxon sign rank test. So coming to the results, the pain in the pre-injection group, as we said, that's between 6 to 7, and it came down to less than 10 at the end of 6 weeks, which was equal in both groups. And it is a similar results at the end of 3 months in both the groups. Complications, no adverse events related to the treatments like rupture, infection, or numbness was noted, but hypopigmentation was noted in 16% of the cases, and only 8% in EPB group, which is statistically significant. Surgery had to be offered in both the groups, but only 1% in EPB and 2% in the both compartment group, which was not statistically significant. So coming to the discussion, many previous studies demonstrated that main lesion of de Quervain disease is the septum, which is stenosing the tenosynovitis of EPB. Thus, targeting this EPB is important to increase the clinical efficacy and decrease the likelihood of subsequent surgical intervention. In this study, an injection in EPB subcompartment alone was effective as an injection into both subcompartments and helped to reduce the steroid dose as well. A study in cadavers found that a septum was frequently present at radial styloid process in the first dorsal extensor compartment, creating a smaller tunnel for the EPB. So, though in that cadaver study, authors suggested that patients whose symptoms are not relieved with initial injection should actually go a second injection that actually targets EPB. Another study done by Bing et al. Also said that ultrasound findings of tenosynovitis were more often found in EPB site in patients with complete subcompartmentalization, and pain was reduced only after the injection into EPB subcompartment. So limitation accepted by the authors in this study, they said that they did not find any APL tenosynovitis alone, which were all more severe APL tenosynovitis than EPB in the 112 patients they examined. So they could not demonstrate EPB targeting injection effectiveness in those. So, and second, they said that they did not surgically confirm the anatomic variation or any histological findings of tenosynovitis. Rather, they just dependent on ultrasound, and the accuracy of ultrasound for identifying the septum could not be evaluated. The third is the severe gender imbalance. So they caution the readers that finding in this study may not apply to men since most of their patients were females. And then blinded researchers evaluated the clinical outcomes and complications, but enrolled patients and surgeons who performed the injections could not be blinded. And finally, the follow-up period was short, just the 3 months, and only one injection was given. When it's already recommended that one injection, if does not give relief, we tend to give the second injection. Critical analysis. So a reasonable option for decurving tenosynovitis treatment along with a reduction in steroid dose, this paper has given us. But the second thing, the ultrasound practice involves a steep learning curve. So hence making the diagnosis without MRI, which is the current gold standard for soft tissue, could lead to false negatives, and also a partial septum could lead to diagnostic dilemma. Along with ultrasound pictures, the probe location on the hand should also have been included. And also ultrasound pictures in longitudinal view probably could have, done the confirmation, like showing the spread of the drug in the separate compartments. So take home message, ultrasound guided steroid injection targeting the EPB subcompartment alone is as effective in terms of pain reduction as targeting both subcompartments in patients with decurving disease who have complete septations. Targeting EPB subcompartment alone can reduce steroid dose and hence the complication. So from authors, they said that we recommend using only single compartment injections in this contest, even among patients with intracompartmental septum. Thank you.
Thank you, Dr. Aanchal. That was an excellent presentation as well. So over to the faculties, Dr. Madan and Dr. Sanjog, for the discussion.
Do we answer any specific questions from the delegates?
There are no questions as of now, but if they come,
Okay.
I'll post it to you.
Yeah, definitely. See, with respect to elbow, generally elbow, I think the particular article which we discussed today is probably the landmark article which will stay for years to come. I think that is one of those articles which all the radiologists and pain physicians must learn by heart, because we do come across with a lot of our ESSR protocols for scanning the elbow, but that actually tells you only the basics of scanning. Whereas we don't get to see those ligaments and small little things like sports injuries when we look at only the ESSR protocol. So it's time to look beyond the ESSR protocol. That's what I feel. And with respect to these medial and lateral ligaments, even though it looks a little bit extensive, the annular ligament, your lateral collateral ligament, radial collateral ligament, all that. To be frank, I'm a person who practice quite a lot of these MSK patients actually. Lot of patients with lateral and medial elbow pain do present with pathologies with these ligaments, particularly those ligaments which actually are injured and treated as a case of lateral epicondylitis do have a small little calcification within the substance of the ligament. I think all of you would agree that actually. So unless we look into these ligaments when there is an acute onset pain, maybe less than 3 months old pain, that is what actually is lacking in many of us. Most of us actually do a PRP injection or a steroid injection, and we do land up with failure. So that is one reason why this article actually assumes a lot of importance, because we need to see those ligaments when we examine by ultrasonography. Epicondylitis, generally, it should not be a diagnosis only by clinical methods. It should be confirmed by ultrasonography. Definitely, it has to be confirmed by ultrasonography. The small little tendinopathies, the calcification dislocations, tears, all that can be really made out with ultrasonography. That is something which everybody must take actually. And thirdly, there are a lot of times, like in places like our own place, like Pondicherry, we don't really have so many people who will take up PRPs. A lot of actually cost constraints are there. So most of the times we do have a patient who is willing for a steroid. And I do come across quite a few patients who are actually given blind injections with steroids. Very senior people, senior orthopedic surgeons who do it blind actually. They just put it into the tendon. And it is very important for all of us to understand the components of these common extensor and common flexor tendons to see and identify where exactly these tears are going to be there. So that's the reason why this article assumes a lot of importance. And when you want to do a steroid injection, for heaven's sake, please see that what plane you want to inject. It should always be done just superficial to the tendon. I think like all of us are very familiar with PRP injections, so which I'm not really going to discuss here at all. I'm going to discuss here something how exactly you proceed with putting in a needle and going superficial to the tendon. Basically, try to create a small little plane, and that is the plane for injection just above the common extensor or the common flexor tendons, not into the tendon at all, because that is what is going to give more injury, because it's already a diseased tendon, which is actually going to be detrimental for the tendon. So these are the things, the medial and the lateral epicondylitis. And thirdly, regarding this biceps, the distal biceps is always a challenge. It's always a challenge. A lot of orthopedicians, a lot of PMR guys actually do miss this actually, but it's one of those very difficult and tricky areas to diagnose and treat as well. Before you actually do, means like you do an ultrasound, everything actually, before you perform anything, any intervention for the distal biceps, I think all of you will agree with this. It is imperative that you perform an MRI before doing any intervention, because it could be just a tendinopathy or a tear or a partial or a complete tear. All this can be identified best with an MRI. Maybe by using ultrasonography, you can use it as a guide for the intervention rather than actually making it as a diagnostic viewpoint. I am one person who will always say distal biceps has to be identified. Even though you can see the tendon, it has to be pathology, has to be confirmed only with an MRI. Joint injections with respect to elbow. As much as possible, please avoid joint injections with respect to elbow unless there is an evidence clear cut that there is an effusion which needs to be drained, or then if there is an arthritis, or if there is anything significant compelling you to put a needle into the joint, please don't do it, because this is one joint where the sanctity of the joint should be maintained. The moment you put in a needle, it goes for immediately a little bit of stiffness. So unless it is absolutely warranted to put a needle into the joint space, please don't do it. Sanjay?
Hello. I think so. Yep.
Sanjay.
I think so. Your inputs greatly added to the all the information that is there in both these articles. And
this article I would have read at least some 20-25 times. Such an interesting article, very
interesting. Yes, yes. And unless it is not only about reading, you have to read and then practice on some volunteer with your machine, and you have to practice many times. Then you'll get all these things. Yes.
Correct.
And surprisingly, we have this topic today, and we have a very nice video put by Dr. Ankit Shah today only of ulnar collateral ligament tear. It was very beautifully demonstrated in an athletic patient, and very nice video was there. So that is one thing. And we also have to, I think, regarding the first compartment things, we have to take into account a lot of other things also. There are a lot of anatomical variations that are there. I just read one article where they did a meta-analysis, and they have found that in the cadaveric patients that they dissected, there were around 0 to 7 APL tendons can be there. The different APL tendons can be there in the compartment. There can be 1 to 6, 0 to 4 EPB tendons in the there. So there are a lot of anatomical variations besides the septum and besides the tenosynovitis and all those things. So diagnosis, just because pain is there in the first compartment and you have to diagnose it as a decurrent tenosynovitis, we should not go with that mentality. And just putting the needle is not our job. We have to diagnose it correctly, and we have to know our anatomy very, very well, so that correct diagnosis will only help your patients, not putting the needles.
Regarding decurrence, whatever is there in that article, I just want to give a little more input on that. Because again, when putting in a steroid, there is, I don't know about everyone who practices decurrence injections. Out of all the patients I see as decurrence tenosynovitis, basically all of them have an intertendinous septum, and there is always a septum above. All of us know that, the retinaculum and the intertendinous septum actually.
Yes.
So probably that is the set of patients who are actually maybe prone for developing a stenosine tenosynovitis. That is number one. Number two, there are a couple of things which you need to see. Most of the times we do not have a hockey stick probe. We are not really blessed with hockey stick probes a lot of times. Because I don't have a hockey stick, but still we need to do it actually anyway. So you could actually shift your probe to one side and then maybe a little bit zoom your screen and just try to put in your needle from one end to the probe. That is one thing, which small little adjustment which I will tell anyone to make. Thirdly, you can actually, I have started doing this last 2 years actually. It's not in a textbook. It's not in a textbook, out of experience which I share. You can actually do a needling in plane and out of plane as well, because doing an out of plane injection really addresses that septum between the two tendons. You really need not worry about whether there was a septum, whether my symptom relief will be 100% or not. Okay, if your probe placement is in such a place, there you can see only one tendon of APL and EPB. That is, if you go more distally, you'll see a lot of tendons. If you go a little bit proximally and stay right over the radial sternum, you will see only 1 + 1 tendon.
Yes.
So that is a place where you put in a needle in plane in an axial view and out of plane from the top, you will address that septum in between the two tendons. So that is something I think, like, I'm using it. I have not read anywhere, but quite successful.
Great. Any questions from the delegates? There are no questions from the delegates, I think. Guys, attendees, participants, please put in your questions if there are any. Otherwise, we'll
And one more thing again of interest, like that's what I say, like, like instead of just putting in a needle into the target, actually see all these things, like the septum in between, the retinaculum. The whole idea of actually going through the retinaculum is basically we do a needle penetration. Okay.
Yes.
Right. There's one more structure which all of us fail to really see. It's like a lot of us really don't look for a good ultrasound machine. The whole idea is to have a good ultrasound machine. You need to look for the sensory branch of the radial nerve as well when you do that. Okay. So the sensory branch of radial nerve, in the intertendinous septum, the needling in means like in plane and out of plane. The same patient you do both in plane and out of plane. Same thing. One side you can inject actually, the other side is just only for the needling, because you just penetrate the septum. So that's the thing. Yeah.
Yes.
Sanjog, any further things you want to add upon regarding decurrence?
No, I think so. You have covered everything.
No, not like that. And anything specifically, means like I don't have an experience about giving a PRP injection into the decurrence actually. What is your experience and what is the literature say?
No, sir. I generally give steroid only. I don't give PRP there. Not there.
Yeah, means like I think anti-inflammatory is the one which will give
yes.
that pain relief. Probably like PRP may not be the thing. Anyway.
Yes.
And do you really advocate giving the steroid injection in the long axis of the tendon?
So I generally give in the eggshell view only. But after giving a good volume, I generally give good local anesthetic and all those things. I don't give just 0.5 ml. And then I confirm it in longitudinal view. How much is the spread and what is this? I generally don't go in longitudinal per se.
Okay, and another thing, particularly with respect to the article also, like I have quite a lot of times tried with this 26 gauge needles actually, lot of times. We do have always a problem with the injection of a particular steroid through 26 gauge.
Yes.
I think here they have used some 25 gauge, but still I will say like always use something like 23 or 2 means like at least 23 for the particular steroid to enter in, because it's a small closed compartment. You will feel very tight when injecting. So
Yes.
it might actually spill over, or you might actually accidentally inject in the intradermal area where you can have a discoloration post-injection.
Yes.
So these are the finer things which I think like we need to make adjustments. But otherwise, like anyway, with all the patients I have seen with decurrence, symptomatic patients, Finkelstein positive patients, always there is a septum. So please don't ignore that septum at all. Probably some people notice it, some people really don't notice it, but that is actually the pathology.
Pathology. Yes.
Great. Dr. Sasmit, Dr. Aanchal, anything from your side?
Actually, if we have time, I wanted to discuss a patient since I mentioned about lateral epicondylitis injection. So recently, I had a patient who was referred to me post 2 times steroid injection done at some clinic, and she had like that white, big hypopigmentation, that white colored, and the MRI was done, and lateral epicondylitis was seen again in that MRI, and then she was sent to me for PRP injection. So at that time, patient was complaining of pain here and in the that brachioradialis side muscle, like this. So since the MRI of elbow did not show anything other than lateral epicondylitis, so I assumed that pain is coming from that, because sometimes the pain radiates in front. So I did the PRP injection of lateral epicondyle tendon, and and then after like 10 to 15 days, the pain at the lateral elbow was completely gone, like 90%, 200% relief. But that this pain would not go away. So she kept of complaining on the pain and the side. So I looked up the literature, what it could be. Then I could find that the involvement of superficial sensory nerve. So, what do you suggest? Like MRI or other diagnostic material did not show anything. So
So it
based
was a case of lateral epicondyle pain, correct? Lateral
right,
elbow pain rather.
right.
Okay, lateral elbow pain. If it doesn't get all right with your steroid, that's what you are saying, right?
No, steroid she already had. She was sent to me for PRP. I did PRP. Pain in lateral elbow was gone, but the radiating pain, in the proximal, in that area, that did not go away in that brachioradialis tendon or superficial sensory branch of radial nerve, you would say. That pain did not go away.
Okay, right. See that's the reason which I say, like all lateral elbow pains cannot be equated with your epicondylitis. So it's basically one is clinical diagnosis confirmed with imaging. I think like for a lateral epicondylopathy, you don't require an MRI basically. So unless you suspect something with respect to the ligaments, probably you might be looking at, say for example, some ligament, chronic injury to the ligament. See, small valgus and varus injuries can cause these ligaments to disintegrate. So these small little injuries, the freak sports injuries, these sports injuries are not essentially sports injuries. It can happen in the kitchen, right? So such injuries really like nobody will really notice actually. What I will simply suggest is somebody who doesn't have a pain relief either with your procedure, or maybe if you think like there is something else actually, do a simple neutral position anterior anteroposterior exposure of the elbow with a simple X-ray before you go for an MRI. I will say there could be a small element of periosteal reactions, maybe what to say, a little bit of calcification between the joint space. You could see, you can't see the ligament by your X-ray. Definitely, there is a small little calcification which probably points towards a calcification. So that is something which you need to address. Secondly, the posterior interosseous nerve syndrome. Uh, Definitely, there are things which how you can actually make it out. One is by examination by ultrasonography. You can always do a nerve conduction study if there is any nerve involvement or not. And if there is any nerve entrapment, high resolution ultrasonography can reveal changes about the fascicular pattern of these nerves. But again, these are all going to be useful only if you have those high-end machines, not in a regular machine. But the patient continues to have a lateral elbow pain, whatever you are saying, around that, just below the elbow. That's what you are saying. Correct?
Just below the elbow pain is gone, but that below pain is not going away.
That's what, just below the elbow, just below the elbow.
Yeah.
So that is what actually it could be a combination of both your posterior interosseous as well as your lateral epicondylopathy. So that could have gone, but what you could possibly do is you can see and clinically examine for if there is anything like a posterior interosseous nerve entrapment. Even if there is a clinically normal posterior interosseous nerve, it is worthwhile giving 5% dextrose hydrodissection for posterior interosseous nerve. Without even a pathology, you can still do it. Even with the nerve conduction study normal, even with the ultrasound being normal, definitely it will give pain relief. It could be small little additions. It could be small little additions.
Yes. So I still have to wait for her to come in my clinic, but that's what I did. So before mentioning it, I wanted to know if somebody.
Actually, PRP also, even we have to evaluate PRP. The results of PRP, I don't actually they come after 1, 2 months, 1.5 months. The actual results that we have to assess in over a period of time. 1 or 2.
1 month had already been passed after that. So lateral elbow pain was completely, that completely went away. But that the lower pain just stayed similar to the one she had before. So I did 5% dextrose.
You are saying right below the elbow, correct?
Yes, exactly that point there, sir, you are mentioning. Exactly that point. Yes.
That place.
Yes.
That's all.
Yes.
This is most likely a posterior interosseous. Even though you don't have any evidence, don't worry. Just go ahead with your dextrose hydrodissection. Definitely it will help. See, dextrose is something which is not going to harm your muscle or your nerve. 100%.
That's what I did. I'm just waiting on the results now.
Yeah.
Great. Sasmit, anything from your side? You're silent.
No, sir. I'm just listening to the wonderful discussion going on. I'm very new to the journey, but all these are very important tips and tricks which actually help us in listening our daily.
Sasmit, I think you did a wonderful job by taking up the topic.
Thank you, sir.
Because it's one of those very, very important topics generally people tend to ignore. Elbow pain. Elbow pain is something very, very, not very commonly managed so easily also. So definitely it is worthwhile reading at least another 10-15 times. Okay. What I want to tell is these ligaments are not for radiologists. These ligaments are for a pain physician. So slowly, steadily, everyone should know this actually. It's time to look beyond the ASSR protocol.
Thanks.
Great. So guys, thank you for the wonderful discussion.
And Sidharth,
yeah.
one moment actually. I just want to take a minute for our upcoming conference actually. I think you could make an announcement if somebody wants to join or something like that.
Yeah, so guys, we have an upcoming conference which is one of the most advanced and most you can say beneficial conference for anyone who's looking forward to practicing MSK ultrasound in pain. And here at a single platform, I don't think you will ever get so many international faculties, and it's very close now. 25th January is just around the corner, and we are looking forward to this. Having all of you there. So those of you who are interested, I'm going to share the link in the chat box as well as. And Dr. Madan, can you just type in the chat box?
Yeah, I'll just type it actually.
Yeah, and also if you can't find it, just mail me mumbaipaintschool@gmail.com, and I'll be very happy to send you that. Quickly, let me maybe let me play the message, and while Dr. Madan is typing this in the chat box. So please join us there, and yeah, it's actually those of you who are looking either to have basic information or even medium to advanced information. So
yeah, it is going to be a festival of ultrasound. Please do join us. Okay.
Great. So I think let me just also just hold on. We have this. Okay, I'm just taking out this chat now. I've got a nice teaser from the meeting. Maybe let me try to play this for you all. Yeah, just hold on. Let me just share the screen, and quickly I'll just. Okay, I hope you all can see my screen now. I'm just going to play this. So I think this is it from our side. So thank you guys for joining in for today's session. We are going to just end this session with the usual niceties and details about the next as well. So this was the season 4 of the Mumbai Pain Schools Pain Journal Club. And first of all, thanks to Dr. Aanchal, Dr. Sasmit for the wonderful presentation. Thank you, Dr. Madan and Dr. Sanjog, for your attendance and
Thank you.
participation. Thank you. Thank you.
Yeah.
And
thank you.
Thank you very much. So this time we had a 8 p.m. time, group topics for seasons, and a 2 faculty 2 paper format, which we found was the most successful one. In addition, we had the papers in advance always one day before. For the next step, those of you who are here for the first time, just join our mailing list, guys. WhatsApp group. Also, the link is in chat. Suggestion, comments, any info, want to talk to me, just mail on mumbaipaintschool@gmail.com. I'll personally reply to your mail. And let's see all of you on the next Friday at 8 p.m. So with these words, just signing out. And of course, do attend our hands-on MIPSI workshop in 26th to 28th April. This is going to be